being with us today.
Thank you, Sarah, for your introduction, and it is my great pleasure to present the favorite topic to your colleague and the student. I have no financial disclosure. So first 20 minutes, I was instructed to give a lecture targeting medical students. So I will give a short overview of NAFLD and the key sex differences in the pathogenesis, epidemiology, and risk assessment and management. At the end of this session, I also want to make some remarks for future physicians and researchers. You might have heard this many times, but the sex and the gender have different contexts. Sex refers to biological characteristics, while gender refers to social cultural aspect, which may differ across society and over time. Both of them are important in human disease, including NAFLD, but my talk today will just focus on biological aspect, sex differences. Non-alcoholic fatty liver disease, NAFLD, is a disease characterized by excess lipid accumulation in the liver, not related to alcohol use. Since most of the cases are related to obesity and metabolic derangement, it was recently proposed to call MAFLD instead, metabolic associated fatty liver. I think this is a more appropriate term, but this has not been widely accepted yet, but you may hear more in the future. 2 decades ago, NAFLD was health problem limited in industrialized countries, but now, due to the global obesity pandemic, NAFLD became a global health issue with the global NAFLD prevalence of 25% and about 33% in the United States. So this is most common chronic liver disease in the United States as well as globally. NAFLD is a broad entity ranging from simple steatosis, non-alcoholic steatohepatitis with and without fibrosis, and cirrhosis. NASH is a histologic definition, steatosis accompanied by hepatocyte damage and inflammation. Some use NAFLD and NASH interchangeably, but that is not correct. NAFLD is a multiphasic disorder and multiple hit involved in throughout the disease progression. Data suggest 3 to 16% of the patient with a simple steatosis develop NASH over time, and less than 10% of NASH patients develop NASH cirrhosis over time. NAFLD with advanced fibrosis lead to HCC, hepatocellular carcinoma, at annual rate of 2.6%. Unlike hepatitis C and alcoholic liver disease, NAFLD patient could develop HCC without having advanced fibrosis, although the incidence rate is much lower, 2.7% cumulatively per the 10 years. This probably related to premature hepatic senescence caused by increased oxidative stress in patients with fatty liver. NAFLD liver has been associated with premature telomere shortening, oxidative DNA damage, senescence marker induction such as P21, and reduced regenerative response. So many factors are identified as NAFLD risk factors, but the the major disease driving factors are these two: visceral obesity and insulin resistance. High BMI, type 2 diabetes, hypertension, and dyslipidemia are commonly associated with NAFLD patients. Many promising therapeutic targets has been and are currently evaluated in trial, but right now, no established FDA-approved pharmaceutical therapies are available to treat NAFLD patients. Lifestyle modification, weight loss, bariatric surgery has been proven effective in treating steatosis, NASH, and even regressing fibrosis. In general, 3% to 8% weight loss lead to improved steatosis and insulin resistance. If patient can lose more than 5%, that will lead to improvement of quality of life, and 5 to 10% or greater weight loss lead to NASH resolution and fibrosis regression. I usually set the initial goal for my patient to lose 5%, but achieving a therapeutic weight loss is a challenge. Probably less than 20% may achieve therapeutic weight loss even with active management. This is an important slide. In assessing obesity, we can't just look at the BMI. You need to consider regional fat distribution because that defines the disease risk. I want you to look at the figure for a second, the right side. So excess energy caused by too much calorie intake or physical inactivities are stored in our body. But where to store the energies quite varies depending on the patient's sex, age, and genetic factors. Some patients accumulate the excess energy in the subcutaneous adipose tissue. It's the left side, green arrow. This capacity is genetically defined, but also influenced by sex hormone and age. Compared to men, women can carry larger subcutaneous fat owing to higher estrogen level. Subcutaneous adipose tissue are safest place to store excess fat. So this phenotype, the green arrow, usually associated with relatively healthy organs, muscle, the heart, and liver. Suppose this capacity is limited for various reasons. In that case, excess energy goes to visceral adiposity, as well as normally lean organs such as muscle, heart, and liver, and causing metabolic disorders and organ damage. So the patient with high BMI, like over 40, could have a healthy liver or minimal steatosis. On the other hand, patient with normal BMI could have NAFLD, even advanced NAFLD. So genetically speaking, patient with disproportionately lean extremities, large abdominal adiposity, and buffalo humps, those people are at higher risk of developing more severe NAFLD. Lipodystrophy is an extreme example. Due to the limited capacity of adipose tissue, patients with lipodystrophy develop ectopic fat accumulation, including liver, and develop organ damage. So do not be fooled by BMI. You always have to assess body composition and regional fat distribution. I'm showing a picture of high-risk features: abdominal obesity and buffalo hump, and disproportionately lean extremities. If you see these features in your patient, you need to suspect NAFLD, assess disease stage, and actively manage. Another important point is NAFLD is a systemic disorder, not just involving liver. The quantity of hepatic fat is positively correlated with systemic endothelial dysfunction, independent of age, sex, BMI, and other metabolic conditions. And NAFLD has been associated with increased risk of cardiovascular disease, chronic kidney disease, and overall mortalities. In fact, top mortality in NAFLD is not liver-related mortality, cardiovascular disease. So systemic management is critical for NAFLD patient to improve overall clinical outcome. And another point is hepatic fibrosis, not NASH, is a strong predictor of overall clinical outcome, including a cardiovascular risk. So the assessment of fibrosis risk in a NAFLD patient is important. This slide shows NAFLD pathobiology and non-sex differences. Excess calorie intake and sedentary lifestyle lead to obesity. Enlarged dysfunctional adipocyte, especially visceral adiposity, lead to the systemic inflammation and insulin resistance, which facilitate energy influx to the liver and increase metabolic stress in hepatocyte. So when hepatocytes fail to adapt, the increased metabolic stress trigger oxidative stress and the direct toxic effect of free fatty acid on hepatocyte and induce lipoapoptosis, which in turn lead to stellate inflammation. And chronic inflammation promote fibrosis and lead to cirrhosis and tumorigenesis. The intestinal microbiota and bile acid play a pivotal role in regulating NAFLD pathogenesis in a multiphasic manner. As depicted in the figure, sex differences and hormonal effect are known in almost all the key elements. I cannot go through all the pathway today, but you can find the summary description in the reference in our previously the published review article. Next few slides, I will give you the essence of sex difference in NAFLD epidemiology that you should know about. In general, the prevalence of NAFLD is higher in men versus women, but there is a significant sex and age interaction. During reproductive age, usually younger than 50, NAFLD is more prevalent in men versus women. But after menopause, NAFLD prevalence significantly increases among women, and prevalence in women become equal or even higher than men's. NAFLD also 2 times more prevalent among postmenopausal women compared with premenopausal women. And postmenopausal women with hormone replacement therapy are at a 30% decreased risk of NAFLD compared to ones without hormone replacement therapy. So all these epidemiological findings suggest that estrogens are protective and a significant risk determinant in a NAFLD. How about hepatic fibrosis? We know the older age, insulin resistance, diabetes, obesity, and hypertension define individual fibrosis risk. But sex and menopause also influence the risk of NASH fibrosis. Premenopausal women with NASH are protected from hepatic fibrosis when compared to men and postmenopausal women. and probably through estrogen protective effect, through the protective effect by inhibiting hepatic stellate cell. Estrogen directly inhibit stellate cell activation and inhibit fibrogenesis. However, the effect of hormone replacement therapy, especially estrogen on the hepatic fibrosis, is still controversial, whether or not it's beneficial or not. Next few slides, I will talk about the sex-specific constellation in the risk assessment. Polycystic ovary syndrome is a prevalent reproductive health issues observed in 1 in 15 women and associated with obesity, excess androgens, insulin resistance, irregular menstrual cycles. Polycystic ovary syndrome has been associated with increased risk of NAFLD, as well as advanced form of NAFLD. This is one of the most important risk factors among young women. Clinically, the patient present excess hair and acne and increased abdominal fat due to the excess androgen, and acanthosis nigricans due to insulin resistance. These are representative picture of the patient with polycystic ovary syndrome. Menopause is another crucial risk factor among women. After menopause, women experience increased abdominal adiposity, increased risk of hypertension, diabetes, and other insulin resistance metabolic features. Menopause increased the risk for NAFLD, but also NASH fibrosis. An important point is the length of estrogen depletion matters. Premature menopause has been associated with increased risk of NASH fibrosis. So age at the menopause should be obtained as a part of risk assessment. Interestingly, androgen exert opposite effect in men and women on visceral fat, NAFLD, and NASH. Detrimental in premenopausal women, but protective in men. Further, in men, testosterone replacement therapy has been associated with improved insulin resistance, the serum lipid, and visceral adiposity. What is a sex-specific consideration in NAFLD treatment and management? Unfortunately, no data to make any sex-specific recommendation at this point. A future agent should be evaluated with a proper consideration of sex differences. As I mentioned, weight loss has been proven to improve steatosis, NASH, and NASH fibrosis. Notably, women need more significant weight reduction to achieve histologic improvement compared to men. The previous study showed that the most men who achieved greater than 7% showed NASH resolution, but the women required more than 10% weight reduction. Which diet or exercise is more beneficial to specific subpopulations, such as postmenopausal women, need to be evaluated in a future investigation. Next few slides, I want to convey my message to the future physicians and researchers. Please pay attention to the patient reproductive health and the status in your practice. Collect the menstrual status, the infertility information, pregnancy history, contraceptive use, menopausal status, and use of hormonal replacement therapy. For men, any sign of a symptom of low testosterone. collect these data and correlate with disease risk and outcome, learn more, and advance medicine. I believe without considering sex, gender, and reproductive status, we cannot fully achieve precision medicine. That's my thought. And when you analyze clinical data, be mindful. Sex hormones and regulate various physiological pathways in the aging process. So it is not appropriate to assume age equally affect men and women. Although some may say it's a standard practice, throwing age and gender in a multivariable model and analyze all together is insufficient. We have to incorporate our biological understanding into analytic approach, communicating this importance with the statistician. Sex difference are attributed to not just different sex hormones, but also sex chromosomes. So depending on involved pathway, factors could associate with outcome in men and women differently, which is blue. Or premenopausal women behave differently from men or postmenopausal women, which is orange. We have to consider this possibility and reflect them in a study design and analytic approach. This figure shows number of annual publications that reported sex or gender differences in an NAFLD and relevant areas. As you can see, number of publications increased over years in all the field, which is encouraging. But despite body of evidence provided in other fields, sex or gender difference in NAFLD has not been well studied. Less than 30 publications per year, when overall NAFLD publication exceed 4,000 per year. So there are a lot to explore in this field. And this is the last slide of the first session. This is Mount Fuji, the highest mountain in Japan. It is active stratovolcano like Mount Rainier in Washington State. It's very symmetrical and it's a cultural icon of Japan. It is well known worldwide, but there are some hidden unexplored area called Sea of Trees, a deep forest on the northwestern flank of this mountain. It's about 12 square miles. It's harder to imagine, and such unexplored, mysterious areas exist in plain the site. I think sex difference in liver disease are unexplored area in plain sight, and you can't know until you look into and explore. And opportunities are waiting for you. Thank you. That conclude my the first session. And Sarah, should I take any question or should I move forward with second session?
Unless you think, I don't know, I'm thinking my question might be addressed later because I had a question about transdermal versus oral estrogen in menopausal women and if there was a difference in how that affected liver.
Okay, so can we then discuss that aspect after I finish all the presentation?
Yeah, let's do that.
All right. So in the second session, I will provide more details. In general, I have to go through several slides to emphasize the significance of sex differences for more general audience, but I don't think that's necessary for this audience. So I will just dive in key sex difference in the NAFLD. So in this section, I will cover more detailed of sex difference in NAFLD epidemiology, pathogenesis, and discuss sex differences in histologic feature, the hepatocellular carcinoma, and some consideration for future NAFLD treatment. This slide shows the previous the studies done in general population across the different countries. NAFLD prevalence was consistently higher in men versus women when not considering age-sex interaction, just overall prevalence. And out of 10 studies published, only 2 studies considered menopausal status, and additional 2 studies analyzed age-specific sex differences. But the results are consistent. NAFLD prevalence is higher in men during reproductive the age or younger than 50 or 60, but after menopause or older than the age, the prevalence become equivalent. So certainly the impact of estrogen in NAFLD development. How about the children? This figure shows meta-analysis of NAFLD prevalence in the children evaluated in a general population. My apologies, this low quality slide, but the main message is this, figure showed study-specific odds ratio of boys versus girls having NAFLD. Overall, NAFLD prevalence still showed male dominance with odds ratios 1.6. However, I noticed these studies did not consider pubertal stage, which might explain this significant variance observed among the study. Some studies clearly show female dominance, and others clearly show the male dominance. So there are the significant variance. So this one study from Australia evaluated over 1,000 community-based adolescents, but only dealt with age 17 years. Based on the age, we can assume most of them were in the pubertal, middle of the pubertal development, or post-pubertal. NAFLD was determined by ultrasound. This study showed striking female dominance in NAFLD prevalence, 16% versus 10%. And the prevalence of central obesity also showed female dominance, 33% and 10%. It's a little bit counterintuitive, but despite the female dominance in the NAFLD, the visceral fat and adverse metabolic features were more prevalent among boys. So sex difference in the NAFLD and the NAFLD-related metabolic feature significantly differ depending on the pubertal stage. So future study in children might need to consider those the difference in pubertal stage. This is for future evaluation. Here's again sex difference in NAFLD pathobiology. Sex differences are known in most of the elements. Due to the time constraint, I will discuss more detail in adiposity, muscle, cell death, and immune response and inflammation. The women and the men have a distinct regional fat distribution. Glutofemoral subcutaneous adiposity in the females and abdominal visceral adiposity in male. But the differences are not just the distribution, but the adipocyte biology also differs. Compared to visceral fat, glutofemoral adipocytes have a lower lipolytic response to epinephrine and non-epinephrine. This contributed to a lower free fatty acid delivery to the liver at the given level of total adiposity. Also, estrogen lower lipolysis and improves adipocyte insulin sensitivity. So a higher level of estrogen also contributes to the reduced mobilization of free fatty acid from adipose tissue, which lead to reduced fatty acid delivery to the liver. Skeletal muscle is a major organ responsible for peripheral glucose disposal. Young females have a higher insulin sensitivity compared to male. And the sarcopenia is associated with NAFLD and prevalent among NAFLD patients. And recently has been associated with overall mortality, cardiovascular mortality, and cancer mortality. But sex differences in the sarcopenia have not been fully investigated enough for the patient. There is some interesting sex differences in the cell death. Seems like male cells are more prone to necrosis when the cell dies, while female cells are prone to apoptosis. It's interesting because the way to die may influence how strongly induce immune response. Unfortunately, the sex difference in the liver cell death information are not available. This area not evaluated in the liver cells. It's all related to the kidneys based on my literature search. So this is also another area for future investigation. Sex differences in inflammation and immune response are also well known. In general, women mount stronger humoral and cellular immune response than men. As you can see in the table, females show higher immune activity across different immune functions. Stronger response would be beneficial when fighting with infection, but could contribute to immune-mediated pathogenesis and could lead to more tissue damage in response to initiated injury. Males and females have distinct innate adaptive immune responses. So the differences are present throughout some differences are present throughout life cycle, whereas others are only apparent after puberty and before reproductive senescence. So the sex difference in immunity are complex, not just activational hormonal effect. We knew for long that the children with NASH show distinct histologic pattern different from adult NASH. So since the sex hormone modulate the immune response and the repair process, I theorized that the injury pattern observed in NAFLD may change during the pubertal development and conduct analysis using 186 children with a histologic confirmed NAFLD. Pubertal development was defined using a Turner stage for boys and girls. The 3 stages, pre-puberty, puberty, and post-puberty, were analyzed for association with grade of each histologic feature. Steatosis, the left upper, and portal inflammation, right lower, were less severe among more developed children, while Mallory-Denk body, the left lower, one of the features of hepatocyte damage were not observed before pre-puberty, but more prevalent among children with a higher stage of puberty. These changes were observed regardless of sex. the two histologic features, the lobular inflammation and hepatocyte ballooning, showed sex-specific association. Black bars represent the boys and white bars represent the girls. Right panel shows the association between severe hepatocyte ballooning and the pivotal stage. Hepatocyte ballooning is another histologic feature of hepatocyte damage and a strong predictor of hepatic fibrosis in adult. Among a girl, the white bar, the hepatocyte ballooning was only observed after puberty. Pre-puberty is just the 0%. And after that, over 20% of the girls had hepatocyte ballooning. However, among boys, the hepatocyte ballooning was less severe and at the higher developmental stage. These findings suggest that sex hormone modulate how hepatocytes cope with metabolic stress and injury, manifesting diverse histologic changes throughout puberty. Now I switch to adult. As I briefly mentioned in the first section, fibrosis risks significantly differ by sex and menopausal status. This study was done using adults with histologically confirmed NAFLD. The slide shows the prevalence of advanced fibrosis among the premenopausal women, postmenopausal women, and men. The prevalence of advanced fibrosis is the lowest in premenopausal women and highest in postmenopausal women, and there is significant statistical significance among this the sex and the menopausal category. Sex differences were also observed in NASH histologic features such as lobular inflammation, hepatocyte ballooning, and Mallory-Link bodies. The strong histologic predictor of hepatic fibrosis are the hepatocyte ballooning and portal inflammation. No difference in portal inflammation, but the hepatocyte ballooning was more severe in premenopausal women compared to men. Mallory-Link body and lobular inflammation also showed more severe histologic feature in premenopausal women compared to postmenopausal women and men. This is counterintuitive because, as I showed in the previous slide, the premenopausal women showed the lowest the prevalence of advanced fibrosis compared to the postmenopausal women and men. We don't know the exact answer, but we theorize that higher the female sex hormones may drive stronger inflammation in the cellular damage in certain circumstances, but estrogens still protect from fibrogenesis via direct inhibition of stellate cell activation. Sex difference still exists in hepatocellular carcinoma. This study includes all-cause HCC, not just NAFLD. But there is a significant sex difference in a cohort. 76% are men, and women are only at 34%. Further, men are diagnosed 4 to 7 years earlier than women across race and ethnic group. Interestingly, overall survival from HCC also differ by sex. women aged younger than 65 are more likely to survive from HCC longer than men, but after 65, survival become equivalent. This is large case series studies including only NAFLD patient with advanced fibrosis to investigate factors associated with development of overall mortality, that is left column, decompensated cirrhosis, middle, and HCC in the right column. Compared to female sex, male sex was associated with 90% increased risk of overall mortality and 7-fold increased risk of HCC development. This study did not address effect of menopause on these outcomes, but another study reported bilateral oophorectomy poses increased incidence of liver cancer among women. So due to the time constraint, I will just introduce my recent review paper, which summarized sex disparity in hepatocellular carcinoma, and we covered epidemiology and mechanistic aspect in tumorigenesis. Next 2 slides, I'm going to talk about genetics. Gene expression are different between males and female, qualitatively and quantitatively, and such sex differences were evolutionarily preserved. This study analyzed the hepatic gene expression in human and other primate. The sample size was small, but they observed distinct sex differences in hepatic gene expression across the species. Most prominent, the sex differences was observed X chromosome and lipid metabolism, catabolism, steroid metabolism, and ATP synthesis, RNA splicing and the binding, the processing, and immune response and wound healing. So those pathways they showed consistent sex differences across the species. Right now, most of the hepatic gene expression analysis done using entire population, not separating men and women or pre or post-menopausal women. But I think the sex-specific analysis on the gene expression is crucial in the future investigation. So based on those information, we hypothesized that sex and reproductive status also modify the effect of genetic variant on a disease condition. We recently published this, the proof of concept study in NAFLD, demonstrating that metabolism-related SNPs are associated with hepatic fibrosis in a patient with NAFLD differently by sex and menopausal status. Unfortunately, our SNP chip used was not comprehensive, and we didn't have sufficient statistical power. We just have 600. But the disparities by age and sex are not considered in the most gene association study in the field. So I believe this is another important consideration in the future gene association studies. So sex differences in NAFLD treatment. No data to support sex-specific approach in a pharmacological treatment at this point. I believe there are different therapeutic targets based on age, sex, and menopausal status. But unfortunately, most of the clinical trials are not designed to address sex difference in the therapeutic response. I believe they are not collecting data on menopausal status either. Several years ago, I was involved in secondary analysis using data from negative study. High quality fish oil from Japanese company was tested in a NASH patient for histologic improvement. Overall, this study was negative, but when I reanalyzed data by age and sex, the analysis showed a significant histologic improvement in women younger than the 50. But small sample size and unbiased cohort, the finding was inconclusive. The sex differences could be observed in the safety profile as well. So we need to change how we conduct the trials systematically. To emphasize that point, the recent computational modeling demonstrated that male and female livers are metabolically distinct, and several therapeutic targets for NAFLD, such as PIPA gamma coactivator 1 alpha, PIPA alpha, FXR, are sex-dependent pathways. So sex differences could be expected in a therapeutic response and safety profile. As far as I know, the preclinical drug development, most of the experiments are still doing still done using male animal. So there are a lot of things needed to be changed to actualize the sex-specific medicine. As a part of my my effort, I recently worked with a statistician and proposed some methodological solution to address biological disparities by age and sex in a clinical trial. We now know enough the significance of this topic, and what we needed to do next is, I think, propose a solution, methodological solution, study design, statistical approach to cope with these biological disparities. After decades of research in the field, I came to believe that the single algorithm cannot explain all. There may be specific causal pathway leading to the disease progression in a particular subpopulation. Unique aspect of pathobiology should be more explored in a specific population, such as pre and postmenopausal women, and select a specific therapeutic target. This is my last slide. I'd like to emphasize that age, sex, reproductive status are key factors to be considered to actualize, personalize the precision medicine in the future. Thank you for your attention, and I'd like to have your input, question, and discussion.
Thank you so much. If anyone wants to ask a question, you can either put your name in the chat and I'll call on you, or you can also type your question in the chat. I can see there's already one question in the chat there. How about the effect of decreasing testosterone levels with age on severe NAFLD risk of males? Is there any information on this topic?
Mm-hmm. So that's a great question. So my colleague and I recently analyzed large the NAFLD the patient population, and the analysis revealed that the lower testosterone level independent of age are associated with the more severe the form of NAFLD. So we know that the testosterone gradually decline over age, but the independent of age lower testosterone actually contributing to the NAFLD severity. Did I answer sufficiently?
If that person's still here. Dr. McLaughlin.
I have a, excuse me, I have a comment and a question. The comment, first of all, is the lecture was marvelously insightful and informative. Thank you so much for the way you prepared it and the way you laid out the information for us. Domo arigato. Yoko dekimashita. So my question relates to polycystic ovary syndrome, which maybe not all the audience knows, but it's a fairly common disease. We don't hear about it much, but maybe 15% of women have polycystic ovary syndrome. Do you think that the effect on the liver and liver pathology is an abundance of androgen in a female or a decrease in estrogen in the same female, or both? And does it provide an idea for how maybe one of the treatments or a proposal for men with non-alcoholic fatty liver disease could be to change the ratio of estrogen and androgen? We always think in terms of estrogen or androgen, and yet there's always this sort of bimodal kinds of activity which change the overall physiology.
That's an interesting point, and I've been actually thinking about that ratio, but I don't have the strong background in that area. I'd love to learn your, the thought, and possibly we could collaborate in the future. We have a large the size of NAFLD cohort with a repository, so we might be able to develop some projects together. If you were interested in, but right now we don't know which the hormone driving disease severity, androgen or low estrogen or the ratio, we don't know yet. That's a very important question, because when we propose therapeutic intervention, we have to know exactly how we need to modify those hormones. Is that the only androgen, or we need to supplement estrogen, or we have to care about the ratio? I think that's a very relevant clinical question. We'd like to address that in the future.
Thank you.
And that kind of might segue into the question I asked earlier about, do you know anything about transdermal versus oral estrogen, if those have preference for patients with this disease?
So Sarah, I don't know if we are really convinced if synthetic estrogen actually beneficial or not. For the NASH, and you all know the estrogen supplementation has been associated with increased cardiovascular risk. So we are not currently thinking to initiate estrogen supplementation in postmenopausal women yet. Do you have any idea if certain type of estrogen replacement actually could be beneficial?
Yeah, so there was actually a paper that just came out. I'll send it to you, and they compared oral estradiol, which is the horse estrogen, with the patch, which is 17 beta estradiol, with estrone, which is E1. And they found that both E1 and the transdermal E2 had better cardiovascular profile than oral conjugated equine estrogen. So there is definitely some data out there suggesting that we've been kind of grouping, bunching them all together, but that there are probably differences between the different routes of administration. So. And just because a lot of what they're assuming, the oral E2 is more negative because of the liver metabolism is what they're kind of associating it with. So that's why I was wondering whether, you know, that interacted with liver disease.
That's also another potential, the future study. I don't, I'm not aware any the study looking at the transdermal, the estrogen supplementation versus oral or versus placebo yet. But
Yeah.
if you can send to me, I will look into, and that's very helpful. Thank you.
For sure. Dr. Ogola?
All right, I really enjoyed your presentation.
Thank you.
Just reviewing back on liver disease. My question is, earlier on the clinical portion, you talked about sex hormones are not the only contributory factor to sex differences, but sex chromosomes too. Perhaps in the clinical settings, have you seen studies perhaps looking at interaction of sex hormones and chromosomes on liver disease?
No, I haven't. Yeah, I think the most of the study, the SNP analysis, gene association analysis, actually they kind of excluded genes on the sex chromosome,
Right.
because the analytic approach could be very complex. As you may know, the genes on the X chromosome will go through the inactivation, right, in order
Correct.
to adjust the dose. But the gene inactivation won't happen randomly, seems like. So I think field is still trying to figure out how to cope with that complexity in analysis. And I think it's still a developing area. There is no the study to look at the hormone and also the gene, but that's very interesting, the study though, looking at those, the evaluating sex hormone level at the time of the study, and also evaluate the SNP data. That will be very interesting future study. Yeah.
Thank you.
And Dragana, we have a question, comment from you. Do you want to say it verbally? You're still here?
Sure. Thank you so much, Sarah. This is Dragana. I, as a clinician, I really kind of struggle with this diagnosis. And I think because we're looking at gold standard for diagnosis is biopsy, the other markers, surrogate markers for diagnosis are kind of out there and we don't know what's a good predictor. Do you have any idea of any guidelines being worked on or written kind of suggesting who to screen, when to screen, how to screen, and things like that?
Yep. So the AASLD, it's a liver disease association, and European Association also providing some guidelines. So if you are interested in, I can send those to Sarah, and probably Sarah can distribute to you all. And yes, there are some guidelines. Yes.
Thank you very much.
Can I ask you which aspect you are struggling?
Well, I think a lot of it is just who do we screen and when we do screen. So let's say we decide to screen postmenopausal women or older men, or kind of, it seems like all of the markers like ALT, AST are not that great at telling. And then the ultrasound, sure, it can show some fibrosis or not. And then where do we go from there? So right. I think all of it really, which of those markers are good ones to go by.
Yeah.
So what I do essentially is I try to screen for a few things and send them to GI But how many GI people are out there, right? So we can't expect them only to take care of these people.
Right.
So-
That's a really good point. You are general internist or endocrinologist?
Endocrinologist.
Endocrinologist. Okay, so I think for endocrinologist, the patient who have diabetes certainly needed to be checked for liver enzymes, and also we look for lower platelet count, because the gradual decline in the platelet count is actually very good marker of the severe NAFLD. If a patient showing any sign of advanced fibrosis, or the features that showing high risk NAFLD, you might want to send to GI for fibroscan or further evaluation. You can also use FIB-4 score that will be included in the guideline, and NAFLD, the fibrosis score. Those are easily calculated using, the routine lab the data and BMI, and also the patient information. So those things can at least use to categorize high risk and low risk, and navigate your decision.
Thank you very much.
Yes, thank you very much for your talk today. I think that concludes the questions. So I'll be sure to send you that paper, and yeah, any information you want to pass on to me, I can pass along to the audience. Thank you so much.
Thank you so much.